Most people have a very clear picture of what a heart attack looks like. They have seen it in movies. They have heard about it from friends. They have read about it somewhere. The image is almost always the same. A person, usually a man, clutches his chest, staggers, falls, and that crushing chest pain is the signal that something is terribly wrong. And while that image is not entirely wrong, it is dangerously incomplete. Because for a very large number of people, particularly people over 65, and particularly women, a heart attack does not look like that at all. It looks like fatigue. It looks like indigestion. It looks like a backache. It looks like feeling off for a few days. And because it does not match the image, people wait. They tell themselves it is probably nothing. They take an antacid. They lie down. They decide to see how they feel in the morning. And those hours of waiting can be the difference between full recovery and permanent heart muscle damage, or between life and death. I am Dr. Daniel Chen. And today I want to talk to you about something that I believe every person over 65 needs to hear. Not because I want to frighten you, but because understanding this could genuinely save your life or the life of someone you love. I want to explain why heart disease and heart attacks present differently in older adults, and particularly in women, than in younger adults, and then the classic picture most people carry in their minds. Because that gap in understanding, that disconnect between the real symptoms and the ones people expect, costs lives every single day in the United States and in countries around the world. So let us start with some real numbers, because they matter. Heart disease is the leading cause of death in the United States for both men and women. According to the Centers for Disease Control and Prevention, about 805,000 Americans have a heart attack every year. Of those, about 200,000 are in people who have already had a heart attack, and about 1 in 5 heart attacks is what doctors call a silent heart attack, meaning the person did not realize they were having one at all. Now, the risk of heart disease rises significantly with age. After 65, the risk accelerates, and by 75 and beyond, heart disease becomes the dominant health concern for the majority of older adults, regardless of gender. Now, let me explain what is happening inside the heart during a heart attack, because understanding the mechanism helps you understand why symptoms vary so much from person to person. Your heart is a muscle, a remarkably powerful and tireless muscle that beats roughly 100,000 times per day. Every single beat requires a continuous supply of oxygen, and that oxygen is delivered through a network of blood vessels called the coronary arteries that wrap around the outside of the heart, supplying its muscle with blood. A heart attack occurs when blood flow through one of these coronary arteries is suddenly blocked, usually by a blood clot that forms at the site of an unstable plaque. A plaque is a buildup of cholesterol, inflammatory cells, and other material that has accumulated inside the arterial wall over months or years. When that plaque ruptures, or when the arterial surface becomes disrupted, a clot forms rapidly and can block the artery completely within minutes. When blood flow is blocked, the heart muscle downstream of that blockage begins to be starved of oxygen. Within about 20 minutes, without oxygen, heart muscle cells begin to die. And the longer the blockage persists, the more muscle is lost permanently. This is why time is so critical. In the treatment of a heart attack, the phrase that cardiologists use is time is muscle. Every minute that passes without blood flow being restored is more heart muscle that is permanently damaged. Now, here is where it becomes critically important for older adults and for women specifically. The classic symptoms of a heart attack: crushing chest pain, left arm pain, jaw pain, sweating. These symptoms occur because of the pain signals generated by ischemic heart muscle that is being starved of oxygen. These pain signals travel along specific nerve pathways to the brain, and the brain interprets them in the areas where those nerve pathways terminate, which is often, but not always, the chest and left arm. Now, here is the problem. In older adults, several changes affect how these pain signals are generated and interpreted. First, many older adults, particularly those with diabetes, or those who have had long-standing cardiovascular disease, have a degree of autonomic neuropathy, damage to the nerves that serve the heart and other internal organs. When these nerve pathways are damaged, the pain signals from ischemic heart muscle may be significantly reduced or entirely absent. This is why silent heart attacks that produce no pain at all, are disproportionately common in older adults. and in people with diabetes. Second, as the cardiovascular system ages and as heart disease develops gradually over years, the body sometimes develops what are called collateral blood vessels, small alternative blood supply routes that develop slowly around partially blocked arteries. These collateral vessels can sometimes supply just enough blood to the at-risk area of heart muscle to reduce the intensity of the ischemic pain signal, making the heart attack feel less dramatic than it truly is. Third, the specific coronary artery that is affected determines what symptoms are felt and where. Different arteries supply different parts of the heart, and the location and size of the blocked artery has a significant effect on what the person experiences. A blockage in a smaller branch vessel may produce much more subtle symptoms than a blockage in the left anterior descending artery, which is sometimes called the widowmaker, for its association with large and often fatal heart attacks. Now let me talk specifically about older women, because this is where the gap between the classic picture and reality is arguably the widest and most dangerous. Research has consistently shown that women, particularly older women, are significantly more likely than men to experience atypical heart attack symptoms. In study after study, women presenting with a heart attack are more likely to report unusual fatigue that has been present for days or weeks. Rather than sudden dramatic chest pain, they are more likely to report nausea and vomiting, shortness of breath, without chest pain, pain or discomfort in the upper back, between the shoulder blades, pain in the jaw or neck. That comes on with exertion and eases with rest. Indigestion or heartburn that does not respond to antacids, and a general feeling of being unwell without being able to pinpoint why. These symptoms are not vague or insignificant. They are the genuine presentation of a heart attack in a large number of women. But because they do not match the classic picture, they are often dismissed by the person experiencing them, by family members, and sometimes, tragically, even by healthcare providers. Research published in the European Heart Journal found that women were significantly more likely than men to wait longer before seeking care for a heart attack, and were more likely to attribute their symptoms to something non-cardiac, like stress, anxiety, or gastrointestinal problems. This delay in seeking care translates directly into worse outcomes, more heart muscle damage, more complications, and higher mortality. This is not a small difference. It is one of the most significant and documented disparities in cardiovascular medicine. Now, I also want to talk about something that is extremely common in older adults, and that is frequently misunderstood, and that is the difference between angina and a heart attack. Angina is chest discomfort or pain that occurs when the heart muscle is temporarily not getting enough blood flow. But the blood flow is not completely blocked. Stable angina typically occurs with physical exertion or emotional stress and resolves with rest or with medication called nitroglycerin that briefly dilates the coronary arteries. Stable angina is a warning that the coronary arteries are significantly narrowed and that the heart is working under a constrained blood supply. But it is not a heart attack in itself. However, unstable angina is a different and much more serious situation. Unstable angina occurs at rest or with minimal exertion. It is more severe than previous angina episodes. It lasts longer, and it does not fully resolve with rest or nitroglycerin. Unstable angina is a medical emergency because it indicates that a plaque is becoming unstable and that a heart attack may be imminent. The distinction between stable and unstable angina is something that requires urgent medical evaluation, not a watchful wait at home. Now, I also want to discuss a pattern that many older adults describe. In the days and weeks before a heart attack, research has documented that a significant proportion of people who have heart attacks experience warning symptoms. In the days or even weeks beforehand, these prodromal symptoms, as doctors call them, include unusual fatigue that is distinctly different from their normal tiredness, disturbed sleep, particularly waking unwell or with chest discomfort, shortness of breath with activities that previously caused no problem, a feeling of anxiety or a sense that something is not right without being able to explain it, indigestion or nausea that is unusual or persistent, and reduced exercise tolerance, noticing that walking to the mailbox or climbing the stairs is more tiring than it used to be. Individually, each of these symptoms is easy to attribute to aging or to stress or to an upset stomach. But together, particularly in someone over 65 with any risk factors for heart disease, they deserve prompt medical attention, not a wait-and-see approach, because many heart attacks are not sudden, unpredictable events. They are preceded by warning signals that the body sends and that are missed because they do not match the expected picture. Now let me talk about what to do when any of these symptoms occur, because this is where I want to be absolutely clear. If you or someone you are with experiences any of the following: sudden severe chest pain or pressure, chest discomfort that radiates to the arm, jaw, neck, or back, sudden severe shortness of breath, sudden nausea or vomiting combined with chest discomfort, sudden cold sweat, sudden dizziness or lightheadedness, or a sudden feeling that something is seriously wrong, call emergency services immediately. Do not drive yourself. Do not wait to see if it passes. Do not take an antacid and lie down. Call emergency services right now, because every minute between the start of a heart attack and the restoration of blood flow is heart muscle that is either saved or lost. The fastest treatment for a heart attack is a procedure called a primary PCI, percutaneous coronary intervention, where a cardiologist threads a small catheter through a blood vessel to the blocked coronary artery and opens it using a small balloon, and often places a small metal mesh called a stent to keep the artery open. This procedure, when performed within the first 90 minutes of a heart attack, has dramatically changed survival and recovery outcomes. But it requires arriving at hospital quickly, which requires recognizing the symptoms and calling for help without delay. Now let me also talk about the risk factors for heart disease that are most relevant after the age of 65, because managing these risk factors is the most evidence-based way of reducing the likelihood of a heart attack. In the first place, high blood pressure is the single most important modifiable risk factor for heart disease and stroke. In adults over 65, it is present in 6 in 10 adults in this age group, and it is manageable through a combination of lifestyle approaches and medication when appropriate. High LDL cholesterol, as I discussed in a previous video, is a well-established cardiovascular risk factor, particularly in the context of other risk factors. Type 2 diabetes significantly increases cardiovascular risk, partly through its effects on blood vessel walls and partly through its association with other risk factors, like high blood pressure and dyslipidemia. Physical inactivity is an independent risk factor for heart disease, and regular aerobic activity, even moderate walking, is one of the most consistently evidence-supported protective behaviors for cardiovascular health in older adults. Smoking, if you currently smoke, is the single most impactful modifiable risk factor. You can address the cardiovascular risk reduction from stopping smoking even after 65 is real and significant. Obesity, particularly abdominal obesity, is associated with increased cardiovascular risk through multiple mechanisms, including inflammation, insulin resistance, and hypertension. And atrial fibrillation, which is an irregular heart rhythm that becomes significantly more common after 65, is an important independent risk factor for stroke and for heart failure, and deserves its own medical evaluation and management plan when diagnosed. Now, I want to say something that I think is important, particularly for the women watching this video. Research has shown that women's cardiovascular risk has historically been underestimated, both by patients themselves and sometimes by healthcare providers. Heart disease has long been perceived as primarily a men's health issue, despite being the leading cause of death in women as well as men. If you are a woman over 65 and you have not had a specific conversation with your doctor about your cardiovascular risk, I want you to ask for that conversation. Ask about your overall risk profile, not just individual numbers. Ask whether you should be on any preventive treatments. Ask what symptoms you personally should watch for and report urgently, because your symptoms may not look like the classic picture, and knowing what your warning signs look like before they happen is one of the most important things you can do for your heart health. Let me bring everything together for you now. Heart disease is the leading cause of death in the United States. For both men and women, after 65, risk increases significantly and continues to rise with each passing decade. A heart attack occurs when a coronary artery is suddenly blocked by a blood clot formed at the site of a ruptured plaque, and the heart muscle downstream begins to die without oxygen. The classic symptoms, crushing chest pain, left arm pain, sweating, are real, but represent only part of the picture. In older adults, particularly in women, and in people with diabetes, symptoms are frequently atypical, unusual fatigue, nausea, shortness of breath, back pain, jaw pain, indigestion, a sense of being unwell. These are real heart attack symptoms, and they deserve the same urgency as crushing chest pain. Warning symptoms in the days or weeks before a heart attack, including unusual fatigue, disturbed sleep, reduced exercise tolerance, and persistent indigestion, should be reported to a doctor rather than wait it out. And if severe symptoms occur suddenly, call emergency services immediately. Do not wait. Do not drive yourself. Do not take an antacid. Call, because time is muscle, and the people who save the most heart muscle are the ones who call the fastest. I am Dr. Daniel Chen. If this video gave you information that you did not have before, please share it with every person you know who is over 65, particularly every woman over 65, who may not know that her heart attack may not look like what she has always imagined. That knowledge could save her life. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me whether you knew before watching this video that heart attack symptoms can look this different from the classic picture. I read every single comment, and I genuinely look forward to hearing from you. Take care of your heart. It has been working for you every single minute of every single day of your entire life. It deserves your attention.